enough, I guess Dr. Metzel was more focused about like my bow-leggedness, which is I guess the suggestion was like a tibial osteotomy, but I'm not sure if that would kind of address the weight bearing problems I have or sorry, the kneecap problems I have. So yeah, like I said in the email, like I've learned a lot more about my condition since then, and because uh, I listen to doctors a lot, and I think what kind of happened was that people were kind of just treating the best way they can, and unfortunately, I think my condition just so rare that, and correct me if I'm wrong, I think it's just so rare that like I'm dealing with things that just people don't normally deal with, and most recently. I saw Dr. Fulkerson at Yale, and he's a kneecap guy, and he's the first doctor What's that?
I know John.
Oh yeah, yeah. So yeah, I mean, he holds you in higher regard, as well as Dr. Drew Stein. But yeah, and
What did they? Yeah, what did they say?
yeah. So it's interesting because I brought up patella baja because I looked up my own PubMed articles research and saw that is a possible symptom of just removing too much fat pad. Interestingly enough, 4 other physicians didn't think that's an issue. Like they immediately said, like that's something you're born with. You don't have that. But Dr. Fulkerson said that based off the X-rays, he does think, and I attached the notes too. He's like he does think my kneecap sits a little bit low, almost like a borderline of patella baja. And when I looked up patella baja myself, I just saw all the symptoms just hit me, like come to light, where it's like it feels like you're subluxing the kneecap. It feels like you have hard problem extending. Your quad muscle is lengthened and your patella is shortened. And it explains pretty much all the issues I'm having, in which, I'm on the leg extension machine. I've been doing it for 2.5 years, and I still can't do like the minimum weight 3 reps. Like it's truly like somebody took my powers away, and I limp. I limp tremendously, and the last thing Dr. Folkson asked me was like, "Is your condition livable?" And I'm like, "No, it's not." And he's like, "Well, the only thing I could suggest is maybe a scar tissue surgery, but unfortunately, I don't think I'm going to try putting in a fat pad for you." So, yeah.
The problem with, and we had sort of briefly talked about this.
Yeah.
And let me just pull up your last MRI scan.
Yeah. My last MRI was actually in May 2021. Yeah.
Yeah, that's this one. So when we talk about patella baja, we just measure. So you measure the length of the articular surface of the patella. So that's sort of the back side of the patella. In your case, that's 29. So it's usually around 30.
Okay.
And then we go from the lower part here, we go to the top part of the tibia.
Okay.
It's one way. And those two numbers you want to be within 20% of each other.
Okay. So not much variance. Yeah.
Right. So, between 0.8 and 1.2 is where you want that number to be. And in your case, you're 30 and 32. So if anything, actually, the distance here is a little bit longer than the length of your patella. So this would be within that normal range.
Right. However, he made his assessment based off the X-rays he took at his thing. So yeah, so, and those are weight bearing. This is MRIs are not weight bearing.
That is correct. But so the interesting thing is when you weight bear, you generally activate your quad, right? When you activate your quad, your kneecap goes up.
Right.
So if anything, on an X-ray, the kneecap is as high as it would go, right? Because it's pulled up by the muscle.
Okay, so that adjusts for, potentially that discrepancy that I'm looking for, I guess.
So if anything, on an X-ray, you would have less patella baja than you would have on an MRI scan. Because in an MRI scan, as you were saying, you're relaxed. If anything, your kneecap sits down. So if you're looking for patella baja, an MRI scan would make it look worse than it really is. If you're looking for the reverse, if you look for patella alta, an MRI scan would make it look better than it is.
Okay. I think I get how that's conversely correlated.
So this is another way to measure patella baja. So we talked about the backside of the patella to the tibia, and that's something called Carton de Champ, CDI index. And then the other one is you just do the length of the whole patella to the bottom part of the patella down to the attachment, which is called the tibial tubercle. And that also is pretty good.
Yeah.
So at least based on those two measurements, you don't have what we would call patella baja. Now, the problem with, you said, those symptoms, those are my symptoms. The symptoms are pretty non-specific. So a lot of stuff that happens in front of the knee has the same symptoms that patella baja has. So whether that's just scar tissue, whether that's a cartilage defect, whether that's inadequate quad, all of those patients describe similar symptoms. So if you look up patellofemoral syndrome, there will be a lot of overlap in the symptoms between that and what's described for patella baja. So Fulkerson also kind of shrugged and said, or what was that, the outcome of that meeting?
Sorry, I didn't catch that.
Fulkerson, I was just asking what the outcome of that meeting was. Did he say something, or did he essentially just...
Yeah. So he thinks scar tissue... he thinks scar tissue is playing a big role, but he also thinks, scar tissue surgery, for something like arthrofibrosis, it would, it's a 50-50 proposition if it gets better or worse. And I don't know how that's calculated, but, I believe it. And I think he wanted me to, he measured another thing he caught that no one else caught was that prone flexion, pushing my heels straight on my buttocks, like where you could test your infrapatellar flexion. He said I needed a lot of work on the surgical side, so he wanted me to do that, and he thinks that it could help with my scar tissue. And I've been basically telling all my friends and my girlfriend and stuff, can you sit on my leg so it just forcibly just destroys the scar tissue? And hey, I don't know if it's helping, but just what else do I have to try?
So, this is that ball of scar tissue that you have.
Mm-hmm. Okay, the black. Okay, so the black's the scar tissue, not the white. Okay.
Correct. So the black here, that's the scar tissue.
Okay.
The white down here, that's what you have left.
Okay.
In terms of your own. And this is just pulling up the MRI scan that you had back in 2018.
Okay. Oh, yep. Yeah, very white. Yeah. Yeah. And can you tell that Baja measurement pre and post this too?
That's a good question. So we can.
Yeah.
It's not the same scanner, so it's always a little.
Yeah.
But so take this with a grain of salt. But so here I measure, 30.8 before. Let's call it 30.
Yeah.
And then if we do this, it's 29. So if anything, I would say you have technically a tiny little bit more patella baja before than you have now. So, but that's within sort of the range of measurements.
Yeah. So maybe patella baja isn't the right way to classify this. It might be more so just I have identical symptoms. Like I don't know if I mentioned the email too, but not only do I have the same symptoms of patella baja, but I found out about a sublux kneecap and all those things. I'm like, oh, why can't they do what I don't know the name of it. It's
tibial tubercle.
Yeah. Which I actually try to see Dr. Strickland about, and then they directed me back to you. I'm like, oh, well, it makes more sense that I talk to you again.
No, she's my wife. We do the same.
Yeah. So, no, they told me. I'm like, yeah, I had no idea, but it's a great conversation.
And then also the tibial tubercle osteotomy, the one that we do these days, the technique is also called the full person osteotomy. So he invented that.
Oh, really? Oh,
so
he's a little modest about that, I guess.
If he didn't say you need it, then you don't need it. Because
yeah. Oh, yeah. No, I mean, correct me if I'm wrong. It kind of adjusts for different things, right? Doesn't it adjust for side to side stability versus up to down and stuff? And like,
it can do all of that. But
yeah.
So if you look at this measurement, that's 5.7 millimeters.
Yeah.
That is the lateralization of your tibial tubercle.
Yeah.
Which is what this osteotomy corrects if you have maltracking.
Yeah.
And less than 15 is normal. So you are already in the really low range of normal. So a tibial tubercle osteotomy, you can't really do that because you would make that number smaller, and then your kneecap would start going the other way. And in terms of tracking, your kneecap, if you look at sort of this here to here, and this there to there,
okay,
that's sort of the width of the trochlea, and that's the width of the patella, and the two not only are about the same size, but they're also lined up nicely. Like when you look at this, people who have a tracking issue or a subluxation issue, it's kind of tilted and off to the side, which you're not.
Yeah. So all this is actually, I mean, I'm glad you're explaining it pretty well. But this actually feeds into exactly the problem I have a lot, which is I have all these symptoms and complaints and feelings and sensations in my knee, but they're not really validated with any imaging. And it seems so bizarre to me because how can something that is excised and shaved off have zero impact on the anatomy and the way that I functionally too, the way I function, it's just impossible. I mean, I guess there's so many factors. We could look at like deductive reasoning and everything, but I still don't think I don't think there's an explanation really. And I think maybe this is something that I don't know if this intrigues you at all, but it's something that I'm trying to explain all of my problems the best I can, and I still think just the overall, maybe it's not maltracking is the word I'm looking for, but it's not, the kneecap is just not fitting the way that it's supposed to be, and it's preventing me from walking properly is the best way I could put it. Yeah.
It's not that you don't describe this well. It's pain as you describe it and symptoms as you describe it oftentimes don't have a physical structural correlate, meaning a lot of people have, you're a little different, but a lot of people who never had surgery, who never had an injury, come in and they have pretty similar symptoms, pain in front, kneecap doesn't seem to be tracking right, they have trouble on stairs or with squats. And you get an MRI scan, and it is stone cold, totally normal. So you have structure and you have symptoms. So if you have a structural abnormality, it would make sense to have symptoms. Right? Something's broken, it's got to hurt. And that is true most of the time, but not all of the time. Sometimes I see someone at the MRI or the X-ray looks terrible, but they're doing pretty well. So that's already confusing.
Right. Especially with arthritis, yeah.
Exactly.
Yeah.
Even more confusing is the reverse, when somebody has symptoms, but the structure looks okay. Like, why that? And there's no great analogy, but a headache, for example, doesn't mean that you have a brain tumor. So your brain, your head hurts, but unless you have bad migraine, a regular headache, an MRI scan looks totally normal. So that's an example of where you have symptoms, but there's no structural correlate.
Yeah.
And it's not, by and large, you can't fix a headache or would never fix a headache with a knife, right?
Yeah.
So
you could make the argument that that's what my analogy for my knee was, I guess. Yeah.
So one thing I would say for you is you do have a ton of scar tissue. the issue that we're bumping up against is if you do surgery, that by itself creates scar tissue. So the concern is that if we go in, we sort of get rid of the scar tissue, that it comes right back or you feel worse. So there is a real chance that you will not feel any better. So on the other hand, you're a young guy and you want to figure this out and you need to be better, so I'm all for it. What we can do, but I'm saying this with the total caveat that you might be the same or you might be worse after this. So that is sort of an honest disclaimer. I mean, we can try this. I can go in, I can try and cut through the scar tissue. I can do something called a lateral lengthening where on the side of your kneecap where you have scar tissue, I can lengthen the tissue. I hear you've tried everything. I'm happy to do that. But we might have a conversation 3 months or 6 months after, and you might be exactly the same or worse.
Yeah.
As long as that is okay, then we can go ahead doing this. But I don't want to pile on another surgery and nothing gets better.
So what are the symptoms that could make it worse as a result?
It would just be the same and more. So
yeah.
Now I really can't do stairs. Now I unfortunately I've done this long enough that I've seen almost everything.
Yeah. And what are the factors that determine success usually?
I wish I could tell you.
Yeah.
I truly, and this is,
yeah.
You're a smart guy, and I'm sure what you do, you can figure things out. But in medicine, it goes back to this structure, and symptoms don't always correlate. It is frustrating. It's not just a science where you do X 100 times and 99 or 100 times you get the same outcome. It's not engineering.
Okay. Figured I'd ask because it's that at least that surgery is done a lot more often. So I thought,
Which one?
we might know. Oh no, just like a scar tissue clean up. Yeah.
So there's just a lot of biologic variability. Some people have a bad knee injury and the knee never swells and the pain is not so bad and they bounce back quickly and the muscle comes back. And other people, they have some glancing blow, nothing awful, and somehow the whole knee just scars up. And so how just your genes manage inflammatory response and response to injury is all over the map. And there's no way testing it. That would be nice if we can pre-op test and say, oh no, your chance of getting scar tissue is so high, we should never touch you surgically. There's no test.
Yeah. One question I asked, I had below in the email, was because a lot of my goal has been trying to find imaging that confirms my claims, and I saw on Instagram or something that there's something called a fluoroscopy where you have a live view of kind of what your knee is experiencing. And I saw HSS has that too. Basically, just that's been my huge thing because my gait mechanics are awful, and the way I stand is just constantly just squeeze my quad, release my quad, and my kneecap drops. And my quad is always on. So I was wondering if you guys can, if you're aware, if that type of imaging could be helpful for my kneecap.
So I can't. That's a good question. I can't tell you. So there's a gait lab, but that's really just for biomechanical research. It's not something that we generally use clinically.
Okay, so it's not as for lack of a better word, certain, right? Okay.
No, and then it's also, let's say we watch you walk and you limp or you. It doesn't really tell us. It doesn't come with an instruction manual on how to fix that.
Yeah,
so
that's
even
true.
if he said, "Oh yeah, his patella drops and he has this hitch sort of on follow through, just making things up." What are we going to do about that? So it still gets back to the. At least if you look for a surgical solution that needs to tie into something structural. said, honestly, the only thing I see that potentially we could consider is going in and just with sort of a soft touch, trying to cut through scar tissue and hope that what reforms, because scar tissue always reforms, but what reforms is a little bit looser, maybe a little bit more stretched, and keeping our fingers crossed.
Like a higher quality scar tissue potentially.
Yeah.
Yeah. Well,
like I said, no guarantees.
Yeah, I think that's very likely. Like, because for my surgery, I didn't move my leg for 3 weeks after the surgery. So I think there was irreversible damage. I got infected. There's a lot of things that happened that it was just like, if you could construct the worst instructions, I think that's kind of what I had. So like for recovery. So I don't really know if, myself would react all that way to surgery. The other thing about scar tissue that I think Fulkerson also mentioned was that he, which I'm sure you'd agree with, like just like might have to do with like what I'm experiencing was that like between fat and scar, it just kind of relaxed. Your kneecap sits on the scar and fat a little bit differently, and it kind of absorbs differently, and so like the response you're getting is different a little bit. Like all those like mini sort of characteristics might have to do with maybe why I'm feeling like my kneecap is pushed all the way down, into my joint line, which begs the question. I'm like, which makes me always think about our conversation from last year, being like, well, what if there was fat there though?
Yeah. No, I'm. Trust me, it's not that I don't want to do that. It's just.
Well,
as a first step, I think. Why don't you think about this a little bit in terms of the dividing the scar tissue? I don't want to really take out anything.
Yeah.
Just literally go with the knife, cut through the scar tissue, and leave it like that, and then you can do your post-op rehab right away to stretch that. And the outside part, the lateral side of your kneecap, called the lateral retinaculum, that looks pretty thick in you. So I would lengthen that, where essentially the thick tissue like this, I would divide it lengthwise and then kind of do this and suture the two ends together so that you start with something like this and you end up with something like that. It's called a lateral retinaculum lengthening.
Okay.
So not a release, but a lengthening.
RETIN?
I'll
yeah. Okay.
Push it. Have to hang up.
Well, wait. So like
but I'll send you an email with the description of what I would say.
Sure, sounds good. So you're not actually. That's actually interesting, because I always thought the scar tissue cleanup was that you would shave it off. You're actually just you're easing like the tension almost, right? Like, yeah.
Yeah. So usually I remove it, but the thing is, the body doesn't like a void. So if you remove something, something's gonna come back to fill that void, which will be more scar tissue. So you have just something that's really tight. And if I can cut this and make it gap a little bit, just to release the tension, then something still wants to fill in. But that's okay if it's tight like this, and then we cut it, and then this fills in with scar tissue, but overall you end up with something that now is longer, then that would be okay. And then, well, maybe we don't care if there's scar there.
Right. We're trying to preserve the density here. Instead of just the gap, like you said, right?
Yeah. So does the length. You don't want stuff to get pulled by tight structures.
Yeah. Okay. Yeah.
And I think for now that's sort of the best we can do.
Okay. What kind of diagnostic tools would you use for something like that? Like, would you kind of like game plan with like an ultrasound or something, or is it kind of
an arthroscopic procedure? So it's going in with the scope, see the scar tissue, divide it, and then on the outside part, on the lateral side of your kneecap, there would be an incision that's about, call it 2 inches, that I can look at that side scar tissue, which is in a different area, and just divide that and suture it back.
Okay.
Sort of like
wait, so you could suture scar tissue?
Yeah,
but you can't. You can't suture fat though, right? Yeah.
Fat's so soft that it doesn't.
Okay. And just to recap what you said about the fluoroscopy, you don't think that would be helpful because you can't really do anything with that information. Is that kind of it?
Pretty much.
Yeah. Okay.
Right.
Okay. I guess the last question I wanted to ask, which is actually because I didn't know this conversation would go in a different direction, but I'm glad it did. But the other question I had at the bottom of my email was like about like NIH research and stuff
Yeah.
like that. Like, I do anything to kind of get as close as I can to what it is, whether it's whatever. But I was wondering if, yeah, you know anyone at the research center?
Yeah. I mean, look, I don't claim to know everything.
Yeah.
I haven't heard of anything. I mean,
Mhm.
there's the clinicaltrials.gov website where anything that's in a clinical trial has to be listed. So, you can look in there
Yeah,
and see.
yeah. No, more so like starting an application, like how to get started with something like that.
You mean you starting an application?
Yeah, I mean, I actually talked to them, and they asked me to, just talk to my surgeons, but
That's, I mean, what's
it's a bit
the trial?
ambitious. What would be the trial?
Yeah.
Well, I know I have a unique problem, but I do feel like patients that have ACL problems and severely scarred up fat pads could benefit from my problem too, I guess.
Yep. All right. I gotta move to the next one, but
Okay.
I'll reply to your email. I'll tell you sort of what I was thinking about, and then just let me know. Okay.
Okay. All right. Well, thanks, Dr. Gomoll. Appreciate it.
Yeah.
Yeah.
Bye bye.
Bye.